So it is my great pleasure to invite Professor Kosh Ray, who is Professor of Cardiovascular Disease Prevention at St. George's, to come to the lectern and tell us about statins and diabetes risk. Where are we now? Kosh.
Thank you. Okay, so I've been instructed to stand here and not move, so here we go. So I'm going to talk about statins and diabetes risk. Where are we now? List of my disclosures. So, you know, why do we give statins to people? We give them to individuals because we're trying to prevent cardiovascular disease. So all of a sudden you have these groups of people who feel they're at risk. They feel that they're threatened. You give them a treatment that we've been using for 10, 15, 20 years, and now all of a sudden we're telling them that they're going to get diabetes. So it feels a little bit like this picture here, that you're going to be shot twice. So what is the real truth? Well, one of the first things I want to try and do is put forward this concept and separate dysglycemia from diabetes. So diabetes is defined by glucose levels, by blood glucose levels above a certain threshold. But they may not be one and the same thing when you try to look at what is actually driving the risk of cardiovascular disease in individuals with diabetes. So this was the work done by my clinical lecturer, and one of the important, I mean, this was really quite important because one of the things he was looking at was the association between diabetes and risk of cancers, and what he showed was that in men and women there was certainly an increased risk of cancers. There was a certain number of life years lost as a result. But importantly, if you look at the number of life years lost, particularly when you develop diabetes in your 40s, you're losing about 6 to 7 years of life. Doesn't matter whether you're a man or a woman. And most of those life years lost are from vascular deaths. Now, if you develop diabetes much, much later on, well, you actually don't have that many more years of life left. So the impact in terms of life years lost is much, much smaller. So it's much, much worse when you develop this early. And one of the important concepts to think about, which we don't always do very well, is the concept of time and exposure. There's a lot of debate. If you read any of the papers and you read reviews, you will find this sort of slightly frustrating concept even now when people talk about diabetes increasing the risk by about 1.5 to maybe 5, and it varies between men and women. So one way to tease this out is you get regression to the truth if you take the totality of the world data. And this was, again, something that Rao did, and we did this when we were working in Cambridge together. And we took the world data with about 500,000 people and to ask the question, what does diabetes do in terms of vascular disease risk? And what it does, it doubles the risk of coronary artery disease death, or CHD. And most of those events are actually case fatalities, so it's coronary death. There's also a strong association with non-fatal MI. And unlike LDL, when you look at cerebrovascular disease, diabetes is associated with an increased risk of ischemic strokes and hemorrhagic strokes. If you look at LDL cholesterol, there is no association with hemorrhagic strokes, and unclassified strokes are obviously principally going to be ischemic strokes. So overall, it's increasing your risk of vascular death. One of the things we often do in epidemiological studies is that if we believe something is, if you like, the sum of its parts, and you adjust for those things, then gradually you should dilute the association between that and risk. So if you do that for diabetes, for example, and you adjust, this is coronary heart disease and this is ischemic stroke, and you adjust for a number of factors like BMI, systolic blood pressure, non-HDL, HDL, and triglycerides, you actually attenuate some of that association, but you don't get rid of it completely. This was obviously in 500,000 or so people. We had a smaller group where we had glucose levels as well. So in that population, if you further adjust for glucose and importantly also renal function, you don't get rid of all of that risk. So amongst individuals with diabetes, once you've adjusted further, there's about 60% of risk that is not explained by glucose or renal function. So you've adjusted for as many of the things that we can possibly adjust in this particular scenario. What is it about glucose and risk? So these were individuals here known to have diabetes in baseline. So in these epidemiological studies, many of these people weren't known to have diabetes, but we measured blood glucose. We've gone back and looked at the association between glucose levels and risk. And what's kind of quite interesting is that if you just look at fairly crude adjustments, and these are mean fasting glucose levels, and you look at the levels and risk, that actually it really starts to kick off. It's not a linear relationship. It starts to kick off at around about 7 millimoles. And if you do sort of further adjustments, what's kind of important is these are individuals at the bottom who are not known to have diabetes at baseline. The risk is very different above the 7 millimole threshold. And if you look at, for example, at this, what many people have termed impaired glucose tolerance range, the risk is actually very modest. It's about 17% increase in risk. And one of the things that we've seen is when you intervene with a treatment, you get about half the benefit. And there are a number of trials that have tried to take this sort of population here and reduce the glucose levels, and not surprisingly not shown an effect on cardiovascular risk. If you look at the top here, these are individuals, again, with a known history of diabetes, with good and poor glycemic control. And the main difference, I guess, between this group here and this group is time. They've just had a clinical diagnosis of diabetes a lot longer, whereas this has probably been subclinical. And again, in this patient population with good glycemic control, you've not abolished the risk of diabetes. So again, there's a disconnect between cardiovascular risk from being diabetic and that from glucose. And then finally, this is some data from the British Regional Heart Study, because there's this concept that diabetes is a CHD risk equivalent, and there's some seminal work done showing that if you had diabetes, then your risk of having future heart disease was the same as somebody who'd had a previous myocardial infarction. What we hadn't considered there was how long have you had diabetes, and this is kind of important. So if you look at the bottom here, this is basically compared to a non-diabetic individual without a prior history of myocardial infarction. That's your control group. This is the risk in men with a previous MI. So your risk of future events is increased by about 123%. If you've had diabetes diagnosed and it's been diagnosed in the last 2 years, your risk goes up by about 53%. Clearly not the same as that. However, if you basically had it now for 16 years, it's about the same. So there is an effect of duration of diabetes when it develops naturally, and we don't necessarily know what is driving all of the risk. And then finally, we can actually move towards intervention trials and again ask the question, well, actually if diabetes is all about glucose, then because it's diagnosed by abnormal levels of glucose, then if we normalize that, then maybe we actually abolish the risk. So what you find in this patient population, if you actually lower HbA1c by 0.9%, is that there is actually the most important effect is on non-fatal MI. There isn't an effect on fatal CHD. If you combine fatal and non-fatal CHD, there's a significant lowering of risk. There isn't an effect on stroke that's significant, and all-cause mortality is not altered in this patient population. And one of the issues that you have with all of these trials when you start looking at them is they have slightly different regimens. Potentially with some of the treatments that you've got, you're exchanging one risk factor for another. And this is just the same data broken down by looking at individual endpoints. So when you actually look at these different trials, even though they are different in terms of the modalities being used to lower glucose, there is actually no heterogeneity, suggesting that this overall benefit on non-fatal MI, modest though it might be, is actually related to glucose lowering. And the same is true for fatal and non-fatal MI. There's no heterogeneity across these trials. And interestingly, the ACCORD trial, as you'll see in one of the later slides, which increased all-cause mortality, is actually consistent with these other studies here. This is the data for stroke in more detail, no heterogeneity across studies. And this is the data for all-cause mortality, showing you that there is heterogeneity across studies, largely driven by this study here, where there was a use of particularly short-acting insulins to get glucose levels down very, very quickly. So it perhaps matters how you lower glucose levels. But the one important thing about this is if you look at interventions among diabetics, and you look at the three things that you might want to do. One is lower blood pressure. Lowering blood pressure by 4 millimeters of mercury is preventing about 12.5 events. Lowering LDL cholesterol is preventing about 8.2 events for every 1,000 people that you treat. And lowering HbA1c is having a much more modest effect. So again, the disconnect between glucose and diabetes glucose per se is a much more modest risk factor. And again, to further support that, this was basically a trial using, okay, albeit this is an agent that does potentially increase cardiovascular disease risk, principally non-fatal MI. If you look at a population with impaired glucose tolerance and you basically want to reduce the progression to diabetes, it's not surprising that if you give a drug that lowers glucose, because that's how you define diabetes, over time you're going to have fewer diabetics. That's a no-brainer. It's like saying I give antihypertensive and I've got fewer people with hypertension. But the real question is, are you reducing clinical events? Are you reducing vascular events? And in that particular study, may have been underpowered, etc., and all the caveats, the trend is actually in the wrong direction. So again, a disconnect from glucose and cardiovascular risk. So the summary thus far is that diabetes and dysglycemia, at least in my opinion, are not one and the same thing, and the cardiovascular risk associated with dysglycemia per se, I believe, is a lot more modest, and that's relevant to the later data. So in the early days, there were a number, obviously, there was a lot of interest, largely from Chris and others, looking at the WASCOP data, where using a slightly different definition to the one that was used in this particular analysis, there was a suggestion that statins, potentially because of anti-inflammatory effects, have a lower risk of diabetes. It was using a slightly different definition. It was actually significant, and to the left, suggesting there was a protective effect. And then as more and more statin trials and data have come out, and we've followed up these sort of individuals, and we've looked at other things in a bit more detail in more recent trials, there was a signal that in a trial where in a primary prevention population with less than 20% framing and risk, giving a very powerful statin, a really good drug that reduced all-cause mortality, reduced a combined fatal and non-fatal MI, there was a 26% increase in the risk of diabetes. Now, the question is it the drug? Is it the population? Is it a class effect? Is this real? It could be a chance finding. You start looking at some of these additional things, and then you might find an association. So one of the things that we were doing is that we were looking with Chris and Naveed Sattar and colleagues, looking at other studies. And in the PROSPER trial, there were actually serial glucose measurements. And what we did is, when we looked at that, we found that actually glucose levels did go up in those individuals given a weaker statin, but in a slightly older patient population. So it would suggest that this is not an effect totally limited to rosuvastatin. When we submitted the data with a limited meta-analysis to the Lancet, the Lancet were, rather than looking at the individual sort of studies, they were much more interested in a combined analysis, really, to look at the totality of the data. So we wrote to a number of the other studies, and we got their data, and we've combined that in a meta-analysis of 93,000 individuals. So you've got the largest data set that was actually available from trial data. And what we found basically was that a statin versus placebo increases the risk of dysglycemia above a level that you would define as diabetes by about 9%. Even though you've got lots of different statins and different trial populations, these are all statins versus placebo, there's no heterogeneity in terms of the effect. So it would suggest there is a class effect. In absolute terms, this is one extra case for every 1,000 people that you treat for a year. When you basically look at the data by subgroups, pretty much when you combine the data, there's only one trial of lovastatin, pretty much all of them tend to go to the right. And I've said to you, the one test you should look at is the test for heterogeneity, and there was no heterogeneity between statins. The only thing that we found, and this is called meta-regression, where we plotted actually this is the wrong slide, but essentially we plotted the age of the cohort. So if you look at whether or not it is an LDL lowering effect, or whether it is something else. If you plot the relationship between LDL achieved in these trials and risk of diabetes, there was actually no significant association between the LDL and risk of diabetes. So that tries to answer the question, is it the drug that's doing it, or is it what you're altering? So there was no relationship between achieved LDL and risk of diabetes, because otherwise you'd expect a significant slope. So despite this trend, this is not significant. But what we did find, though, is when you look at age and the age of the cohort, there was a strong slope. So one of the biggest predictors of developing diabetes was in older populations, giving a statin increased the risk of diabetes. And that probably explains the effect in the Jupiter and the other trials with rosuvastatin, who are an older patient population. Now, if this is real, one would expect a dose effect. So we have 5 trials of high versus low dose statin therapy. And what we found was that you've got a 12% now increase in the risk of diabetes. However, you've got a 16% lower risk of cardiovascular events. So for every 1 case of diabetes, you're preventing 3 events. Are there differences between drugs? So these are the 2 drugs used in the high versus low dose statin trials. And this is quite a nice way to present the data. So if I walk you through that, then a high dose of atorvastatin compared to a standard dose increased the risk of diabetes by 15%. Simvastatin does so by 13%, and 13 and 15 are not statistically different, so they're both just as bad. Look what happens when it comes to prevention of cardiovascular disease. Atorvastatin 80, by virtue of the fact you lower LDL more, gives you 22% prevention of cardiovascular disease, compared to 5% non-significant lowering of risk. 22 and 50 and 5 are statistically different. So if you look at net benefit, you wouldn't choose this regimen, you choose this one at the top. What we do know is that when you give statins to individuals with diabetes, that you do prevent a number of major cardiovascular events. Per millimole, there's about a 23% lowering of risk. You do it irrespective of whether you're diabetic or not, so the benefit in individuals with diabetes, even though glucose control might become slightly more deranged in those individuals, you don't attenuate the benefit. If you give individuals with diabetes a more powerful dose of a statin and you lower LDL by a further 0.6 millimoles, with or without the metabolic syndrome, you actually further reduce the risk of cardiovascular events. So if your risk of cardiovascular events is very, very high, there is clear evidence that that is more important than any of the effects really that you might get associated with dysglycemia. The other important factor is that when you treat individuals with statins over time, the longer you treat, and this was some of our data from the Prove It trial, where you look at the benefit in the first year with a high versus low dose of a statin and in later years, you tend to start, and we saw this in the HPS trial as well, you tend to get more benefit over time. And if you look at multiple events, because atherosclerosis is a progressive process, this is data from the TNT trial, the number of events that you prevented, the first event was 262, but some people get a second, third, fourth, fifth, sixth event. So if you look at the total number of events that you prevent over time, the benefit in high-risk individuals clearly is going to favor statin therapy over and above the risk from dysglycemia. In these 3 trials, there were measurements of glucose over time. And one of the questions that was asked was, if you do develop dysglycemia, do you attenuate the benefit from statin therapy when you lower lower LDL by a further 0.6 millimoles? You don't have enough power to see significance. It's a small group of individuals, but this overall event reduction or this trend was consistent with the main analysis, suggesting that even those individuals who develop dysglycemia continue to benefit. And in a prime prevention population, the Jupiter trial, this is a publication this year in The Lancet, basically showing that overall, rosuvastatin reduced risk by about 44%. In the population that developed diabetes, you still got a 37% lowering of risk, 0.63 and 0.56 are statistically not different by virtue of this overlap, at least over a short period of time. I can't comment on long-term data, and nobody can. In the Jupiter trial and the TNT trial, if you look at predictors of risk predictors of developing diabetes on statin therapy, these are really the components of the metabolic syndrome by and large. And the more of these you have, the greater your risk basically of developing diabetes, certainly in the future. So In conclusion, cardiovascular risk is not explained by glucose levels. We know that statins are associated with dysglycemia, and it would appear that at least with statins this is dose dependent. In the short term, the consequences of dysglycemia are offset by the cardiovascular benefit. We can't really comment about the long term. The one thing that none of the trials thus far have looked at, we know that dysglycemia is associated with microvascular disease. None of us are absolutely certain what the long-term effects of this are on microvascular disease, so for example, on retinopathy or renal disease. And one of the things that's being postulated is that any of the trials that now are done, particularly with lipid-lowering agents, should screen for dysglycemia or lipid-altering agents, and secondly, should also follow these individuals up over a period of time to see if there are any long-term consequences should they develop. So thank you for listening.